With I give this color doctor and 2 different paragraph transfer assay. I prefer not to use only 2D. Go to the V2. So what we do is not only 2D, we also do modes, we also do doctor, tissue doctor, and other modes also. That is why it is better to use the word echocardiography. But somehow conventionally I am using the color doctor and 2D because when we added color doctor to 2D, that's a headache came. Before when I started practice, color doctor was not available. So we had only 2D and then more. And transthoracic, why we are writing transthoracic, any idea? There is something beyond. So something like trans-abdominal ultrasound means there is something other than that. Otherwise we would not have called it as trans-abdominal. We would have called it as you just casual ultrasound. So transesophageal is one. Any other? Any other echocardiography possible? Transesophageal is okay then. One is based on the location of the probe, another is based on the technique. So this is like in radiology, plane and contrast we speak. So this is plane, right? Plane study, transthoracic. So you can do contrasted. So ultrasound conference or a saline with air bubbles can be pushed and it can generate echo signals. So contrast echocardiography is possible. Then stress echocardiography is possible. Of course, I won't do it. Just to have a familiarity with the terminologies. So stress echo is nothing but exercise ECG like PMT we have, that is stress ECG, where patient is meant to walk or even certain pharmaceuticals. So that will produce stress on the myocardium and changes are visualized. Same thing can be done even in echocardiography, stress echocardiography is possible. The another thing is para-operative echocardiography. You can keep the probe on the heart and endocardiac probe. Something like endovascular ultrasound, you can have an endocardiac echocardiography. That may be useful in advanced cardiac surgeries, especially the placement of the artificial valves by cutaneous techniques. So these are the newer methodologies which are available. Am I obstructing the view? I think I can stand here. Otherwise, maybe down. So, what is the next? What is BSA?
Body surface.
Yeah, body surface. How do you calculate body surface area? What are the parameters required? Height and weight. It is not BMI. BMI is different. BSA is different. Body surface area, roughly the skin surface. So, why it is relevant in echocardiography? Like when we do obstetric ultrasound, we want LNP and gestational age. Why we need? Why can't we do straight away? What is the purpose of having the gestation age by GA by LNP? People ultrasound. You can just speak, no hesitation. Even if you are telling wrong, it's okay. Even today I will be making a wrong statement. No problem. Why we need?
To know whether the growth is relevant to the gestational age.
Then you can assess in fetus, right? I mean, by ultrasound itself we can see the growth and all those things. But why you need LNP? To compare. See, unless you know the real fetus age, we cannot say whether the fetus is large or small for the gestational age. It is something like you are seeing a child which is equivalent to 6 years of age. If somebody asks whether the growth is good, I need to know the real age. If I say real age is 10, then you are going to say that child is not growing. Suppose if I say child age is 4, then you will look at the same child and you will say that growth is more. So whether growth is more or less depends upon the reality. So here, whatever sizes we measure, when we say enlarged or not enlarged, it is based on the average person's perspective. So if the person is very short and very thin, their body surface area will be low and their normal chamber will be smaller. So-called normal sized measurement may be abnormal for them. It is something like for 40 weeks of pregnancy, if you get 30 weeks fetus, it is IUGR. Similarly, if you know the body surface area, we do what is known as indexation. It is not required for all cases. select cases it may be required, or a select parameters it may be required. So that is what we are trying to do is we are comparing with the body surface area of the person. Then we say whether this particular measurement is normal or not. Similarly, gender is also important. For females, you may have a normal cutoff which is different from males. So that is why gender is important. Of course, it will be there in the header. I am not included. So gender is required. Height, weight, body surface area is required. Why BP is required?
Hypertension cases, coagulation cases.
Not only adults, even in children also.
Upper limb, lower limb difference.
Yeah. So there is one is for clinical clue. Whether the patient is having hypertension or not, and whether there is any difference you told, that is okay. But not for aortic obstruction cases. For a day-to-day cases, without any arterial disease, for intracardiac abnormalities, we are trying to assess systolic, diastolic functions. These are the basic whatever we are assessing. During that period, whether knowing the BP of that particular patient, whether it makes sense or not. Suppose if the BP is very, very high, then what will happen? Systolic function will be, it can be slightly deranged because of that itself. Excessive load. So even though you are a competent person, if you are asked to give a output which is beyond your limit, then you will fail. It is something that if you ask someone to score 100 runs in 20 balls in cricket, it may not be possible at all. You may be Sehwag or you may be Abhishek Sharma, but still, that is beyond your scope. Similarly, if the BP is, let us say, 200 to 150, normal heart cannot really pump properly. So naturally, the increased afterload is going to produce a problem for the functioning. So that gives an indirect clue. Otherwise, you will know, okay, whether the patient is hypertensive or not. So if there is a patient is having hypertension, you can expect certain hypertensive heart disease observations. So you are using the information for your own correlation as well as for the exact situation and how it can impact the hemodynamics of that particular patient at that particular moment. So if you do a ejection fraction estimation today with uncontrolled hypertension and the evening after the control of BP, if you repeat, you may not get the same value. You will have definitely some improvement. So that way it will help in a borderline systolic dysfunction with uncontrolled hypertension. You can indirectly you will think that okay, that must be the cause, let us review after a day. So that way you will be getting the information. Similarly, heart rate also can be added here. I usually measure it, but usually in echo itself you will be able to measure. That is why I not put it in the clinical information. Does the heart rate makes any difference in echocardiography? What is the relevance of heart rate?
Computation of cardiac cycle.
If there is tachycardia, does cardiac function come down or go up? Or both?
Ventricular filling will be less.
So with the tachycardia, both can happen. Initially, performance will go up. Suppose if you are frightened, or suppose you are doing some exercise, heart rate goes up to certain level where your cardiac output improves. Then if the heart rate goes further beyond too high, then as you rightly pointed out, the diastolic period comes down and filling becomes inadequate. So when the filling becomes inadequate, output also becomes inadequate. So there has to be a balance. So little higher rate is good, too much of higher rate is bad. So our elders would have told, Ati Adare Amrita Visha. How many of you understand Kannada? 50%? Okay. Good one. Good. So these basic clinical inputs will be important. These are the observable parameters and clinical history, whether the patient is having chest pain. So at least you'll be knowing, okay, we are suspecting either acute cardiac event in the form of MI or pulmonary embolism. So these are the clinical inputs is going to help you to suspect or a focus when you are doing echocardiography. No doubt you have to see all the structures in detail in each and every cases, but still additional focus or a recheck on the particular parameters is going to be useful. That is why the clinical history and a little bit of clinical examination, if you can learn, it is fantastic. During our MBBS days, I think we have studied clinical examination of the heart. How do you examine? Do you remember anything? So I want to know from PGs. What are the components of clinical examination of the heart? First is history taking. In that, chief complaints, then history of presenting illness, past history, and all those things, family history and all those things. After that, clinical examination. First is general examination, then systemic examination, CBS. What four things? Inspection, palpation, percussion, auscultation. Which is fifth? So that is how we have to progress. But of course, there is no need to do detailed inspection, detailed palpation, not really required. And a little bit of knowledge about the murmurs is going to help. Because you can correlate with the timing of the activity which is happening. See, you are also seeing the turbulence, hemodynamic abnormality. That will correlate with murmurs. So, if I say, okay, if I ask, what is the murmur in mitral stenosis? Mid-diastolic murmur. Why you are telling mid-diastolic? Just by memorizing or analyzing? If you are analyzing, you should tell me how you are analyzing. It is very simple. Mitral valve opens when atrioventricular filling happens. So atrioventricular filling happens during ventricular diastole. Isn't it? Suppose if there is an obstruction with turbulence, it has to happen when mitral valve is getting opened, right? So mitral valve opens at diastolic, so naturally it has to be diastolic. Why mid? Because when valve opens, initially some flow will occur without producing any sound. After that, the turbulence and noise will be there. So mid-diastolic murmur. And is there any additional observation we have by heart during MBBS day? Pre-systolic acceleration. Do you remember? What is pre-systolic acceleration? Actually, see, we have studied everything now MBBS days, but without really going into the basics and understanding the fundamentals. So, mid-diastolic murmur, why in MS we are confident? Pre-systolic accentuation, why? See, pre-systolic accentuation means flow is increased. You have a turbulent flow at pre-systolic phase. Pre-systolic phase, what happens? Atria contracts. So, pre-systolic accentuation is because of the atrial contraction. Suppose patient is having atrial fibrillation. There is no pre-systolic accentuation. These things we have studied, right, in previous days. So, we need to just revisit. It doesn't take much time. So, a little bit of talking to each other or listening to our CMEs or some basic articles. Because actually each and everything we know. It is something like Budi Muchi the Kenda Nidaki. So we are, all of us are having. Only thing is we are not aware that we are having. So we already know. So only thing is we find the gaps and then we have to analyze and do it. Okay. So that is about the clinical background. Okay. Then left atrium. What is LAD? Left atrial dimension. How do we measure? We'll see later. Then left atrial inferior-superior dimension. LAIS. LA volume. So how do we calculate? We'll see. So these are the 2-3 important observations we need to know the size of the left atrium, whether it is enlarged or not. Or if it is hypoplastic, even there may be some conditions, congenital abnormality, it can be smaller also. Then left ventricle. Can you just scroll it? What is LVEDD? Left ventricular end diastolic dimension. So that is basically a width of the left ventricle at a particular level. That we'll discuss later. Not the long axis. This is short axis measurement. So LVEDD. Similarly, LVESD, left ventricular end systolic dimension. Then you have interventricular septal thickness. Then you have left ventricular posterior wall thickness. So once you know the full form, the things becomes easy. You would have seen all these things in your echo report when patient is coming for some other imaging or whatever. Only thing is we have not put our mind to it. From now onwards, you start make it a habit to read the report, and if the patient is available, just keep the probe on the heart and see, and compare with their observation and your observation, whether it is matching or not matching. If not matching, why? Whether you are right or whether they are right. So we have to decide, and we have to learn and move forward. So LV geometry. What is geometry? We have studied geometry. We know left ventricular geometry. Basically, this is a calculation using a simple formula based on the above measurements to know whether left ventricle is normal, whether there is a concentric remodeling is happening, or whether there is a concentric hypertrophy happening, or whether there is eccentric hypertrophy is happening. So these are the four things: normal, concentric remodeling, concentric hypertrophy, eccentric hypertrophy. So these are the four types of left ventricular geometry which is possible in population. So we are trying to analyze. So this is very much relevant in patients with systemic hypertension. Suppose a patient with systemic hypertension not having LVH but having a concentric remodeling finding, that makes a additional risk factor for him, and so that we need to control the hypertension in a proper manner so that we can avoid the dangerous consequences. And the terminologies will appear a little complex, but they are not. So what is left ventricular hypertrophy? You would have studied, right, in the MBBS case. What is it? Increase the thickness of the left ventricular myocardium, not because of infiltrative or other pathologies. It is because of the hypertrophy, increased workload. It is something like you have a skeletal muscle bulk increase because you go to gym. That is hypertrophy. Suppose if you have an infiltrative pathology involving the muscle, then it is not hypertrophy. It is just thickening. So thickening can be hypertrophic thickening or non-hypertrophic other thickenings. Here it is hypertrophy we are talking about. So hypertrophy can occur in left ventricle when there is an increased pressure. If there is a systemic hypertension, heart has to work against pressure, so hypertrophy develops. Suppose if there is an aortic valve stenosis, it is acting against obstruction. So these are the two things. Third one is primary hypertrophy, that is hypertrophic cardiomyopathy. So when we say cardiomyopathy, of course this is relevant in day-to-day radiology also. What do you mean by cardiomyopathy? Heart muscle disease. If it is primary, it is unknown cause. In primary you have dilated restrictive hypertrophy. In secondary cardiomyopathies, you are having so many big list. So I will not use the word cardiomyopathy here. I will say heart muscle disease, to have a generic inclusion of no more conditions. So heart muscle disease in the form of LVH or eccentric dilatation, rather eccentric hypertrophy, or a concentric remodeling. Concentric remodeling is nothing but a beginning stage of hypertrophy. So high risk person, high risk stage where the person is prone to get LVH. So these are the subcategories of left ventricular geometry which we can pick up. Okay, let us jump into the next. What is ejection fraction? Majority of the people are fascinated by ejection fraction. There are Christian people say that if you know ejection fraction, the half of the echo is done. This is the standard dialogue, but it is not. It is over exaggeration. So ejection fraction is no doubt important, but it is not ultimate, it is not everything. So can anyone tell me what is ejection fraction? You already know about it.
The amount of the blood ejected by the left ventricle divided by the amount of the blood that is collected in the left ventricle.
Exactly. So what is the percentage of the blood which is pushed out by each cycle? So at the end of the diastole, how much it had? Let us say it had 100 ml. It has pushed 50, 50 is remaining. So 50 is pushed out, so 50%. If ejection is 65%, suppose 65 ml is pushed to the aorta and 35 is remaining, then what is the ejection fraction?
60.
Is it 35 or 65?
60.
Yeah, what is ejected? Yeah, not residual. What is ejected? So if you can compare with the urinary bladder pre-void and post-void, how much urine has gone out? So suppose let us say 400 ml of pre-void urinary bladder and 100 ml of residual urine. So residual urine percentage is 25%. Excreted is 75. So this is equivalent to excreted, not residual. So there is ejection fraction that can be estimated by techniques. What are the different techniques? What we have? Are you familiar with the modes of ultrasounds? What are the modes?
A mode, B mode,
Okay, what is A mode?
amplitude.
Okay, how do you get it? Is it used now? Where it was used?
Only.
Yeah, it was, you could use it in any for body part, but in ophthalmology it was being used. What do you get?
The distance.
Okay, you will get a graph. What is the horizontal axis? X-axis? Distance? Correct, distance correct. What is the vertical axis?
Amplitude of the wave that we get back.
What it denotes what? Huh? Strength of the echo. What is the unit? Is it in millimeters or something else? This is in centimeter or millimeter. In A mode, what is the vertical? What is the unit used? Is there any unit? There may not be, right? Actually, I am waiting for a proper terminology. Amplitude of signal you told, right? In day-to-day terminology, what we can call it as? Echogenicity. Isn't it? If it is highly echogenic, it is on top. If it is less echogenic or anechoic, it is bottom. So anechoic structure will have a value of 0. Highly echogenic, suppose a dense bone or a calculus, will be at 100. So you get a graph, somewhat similar to MRI spectroscope like picture, but it has become obsolete. So that is A mode. What is B mode? What is the difference between B mode and 2D? Am I confusing you? It's up for example, I'm out of the way, so I'll come back. Because actually I am trying to create awareness that the knowing fundamentals is making huge difference. So I cannot teach everything about echocardiography. I am trying to motivate you to learn. That's it. So my job is only very and ability to learn and improve. You have the capabilities. So what is the difference between B mode and 2D? Same. Isn't it same? It is same. Yes. According to me, it is same. If anyone says it is different, I will welcome the point of view. It is same. Why 2D mode is called as 2D? Why they gave this word 2D? Now because we have 3D, 4D, then we can retrospectively we can say that okay, this 2D means 2-dimensional. This is, but actually initial days they coined the terminology 2D because A mode was 1D. It is a single beam ultrasound. Can you give another example of single beam ultrasound other than A scan? Any other modes with single beam ultrasound, which was practiced before the advent of B mode or 2D. Very initial days, 1940s maybe. M mode. The M mode actually imagine people were doing 2D images. So they had to keep the cursor line blindly. That is why they give so much of emphasis on M mode. Nowadays, so many M mode calculations have become obsolete because you are getting a better clarity information with other techniques, say 2D and other things. But because it has given so much of importance earlier, that is why somehow we are hesitant to leave it. See, we want to keep the legacy of that. That's what it is. So basically, the single beam ultrasound is one is the A scan, another is M mode. So 2D and B mode is same. Then what else we have? Color Doppler, color flow mapping. Let us be specific. Color flow mapping. Because when we say color Doppler, we are including many. So color flow mapping. So that is we are doing in day-to-day substrate. So what I am trying to do, you are putting 2D image and we are putting the color on it based on the direction and the velocity of the blood flow which is happening. That is color flow mapping. What is PW? Pulse wave. What are the types of pulse wave imaging? Now continuous pulse wave. Pulse wave imaging types. Pardon? Yeah, color flow imaging is one, yes. In color flow imaging, we are using pulse wave. That I agree. Then, yeah, spectral Doppler. Power Doppler, yes, that is also correct. Spectral Doppler, basically, you are creating a spectrum. What is spectrum? What is the meaning of spectrum? Yeah, wide range of events which is happening, there is spectrum. So, spectral Doppler, otherwise called as time velocity curve, using pulse wave, that is the pulse wave tracings. Then, what is continuous wave? CW. Why pulse wave is called as pulse wave? What is pulse there?
Transit time.
Pulse means right. So we are sending the signal independently and we are receiving the signals independently in a pulsatile manner. So it is a pulse wave. In continuous wave, we are throwing the ultrasound beam continuously, we are receiving the ultrasound beam continuously. That is why it is continuous. Why we need pulse wave? Why we need continuous wave?
Continuous wave we need to,
Now let us understand pulse wave first, because pulse wave we are using, right? Are we using pulse wave only for Doppler or even for 2D imaging? Do we use pulse wave in 2D imaging? Proper liver, kidney ultrasound. Do we use pulse wave? Or continuous wave? Wave means ultrasound wave. No, that's what, sound waves. How do we capture the images? So we are sending the ultrasound beam in pulses, getting the reflections. Why pulse? Why not continuous? Okay, I'll make it simplified. Sorry for confusing you. So basically, how computer generate ultrasound image? How probe knows that echoes are coming from which level and what is the echo density? Yeah, based on the time. So if you want to know the time of deflection, if you are giving continuously, if you are giving the signal, then you cannot know. See, we are throwing the ball and collecting it. Suppose if somebody is throwing a ball continuously and you are collecting, you will not know which ball you are collecting, whether ball number 1, ball number 2, or ball number 3. Isn't it? That's what will happen. That is why you are having a lysing in pulse wave. When the return comes very late, then it is combined with the next cycle or whatever. It gets confused. So that is the reason you need that. So you have to give the signal and you have to get the signal back. What is the time delay? If the delay is more, means echo reflectivity is from the far away. So that is why ultrasound image echogenicity is placed far away. Isn't it? So if the echogenicity is higher up, the reflection will be fast. So basically what we are using is pulse wave even in our day-to-day 2D imaging. In Doppler when we use, we call this pulse wave Doppler. Once again, because we want information from a particular point, we have a sample size, sample volume, which is kept, let us say, 5 centimeter below the probe. We are interested in activity only in that particular point itself. Suppose if you are getting the signals from all the areas, there will be a lot of noise. So SNR comes down and it is difficult interpretation. For example, when you are doing a popliteal artery study, suppose if your sample volume includes popliteal vein, what will happen? You have venous contamination of the arterial vein, and vice versa. So if you are doing popliteal vein ultrasound or Doppler, suppose if you are getting arterial signal and contamination, then your waveform assessment becomes difficult. So that is why we need pulse wave in cardiac when you want information from a particular point. So for example, you are interested in the activity just beyond the aortic valve leaflet for some reason. If you are getting signals from all the areas, then there will be a lot of noise. So pulse wave is very, very useful to identify the Doppler activity and at what location we are getting the Doppler activity. Whereas, what is the limitation of pulse wave Doppler? If there is a high velocity, what will happen? As I say. So, what is the N limit? Yeah, Nyquist limit. What is it? What is the basis of Nyquist limit? Yeah, basically, that's what same thing, because if the signals are coming too late, then it is giving artifacts. So it is summated, and instead of having a forward flow, you will have backward flow. So in summation, you will get lot of aliasing and some sort of mosaic pattern will come. So high velocity jets cannot be measured by pulse wave. For that, we need continuous wave. In continuous wave, there is no sample volume. The whole cursor, not whole cursor, whole line is a sample volume, top to bottom. What at a 15 centimeter depth, if you have selected, the full line is a Doppler sample volume. So suppose if there is an artery, vein going there, everything is summated. But when we keep the line, we place it such a way that area of interest is covered, and we know that some noise is coming from other areas, and we ignore it. We concentrate on the high velocity activity. That is why continuous wave Doppler is going to give you higher velocity flow, which is very common in cardiology, especially aortic stenosis, mitral stenosis, whenever there is a turbulence. So impulse wave cannot measure it. That is why we have continuous wave. Sorry for digressing. What we were discussing. Okay, ejection fraction. Okay. So what is wall motion abnormality? Have you heard about this terminology? Akinesia, hypokinesia, hyperkinesia, dyskinesia, aneurysm. So basically the ability of the myocardium to move normally is getting deranged in regional wall motion abnormality. See, normal myocardium is supposed to contract. The whole left ventricle, just imagine it is having a, let us say, a bullet-shaped left ventricle. It is contracting. All the segments are contracting: septum, posterior wall, lateral wall, apex, base. Everything is contracting, and everything moving towards the imaginary isocenter of the left ventricle. Suppose if one particular part is having infarction. What is infarction? Cessation of blood supply resulting in cellular damage and cellular death, whatever. So when there is infarction, it cannot function, it cannot contract. It becomes like a scar tissue. So that area will not contract. Then it is a regional wall motion abnormality. Normally we expect all the segments to contract and move towards the imaginary isocenter of the left ventricle. What happens to the mitral valve annulus during the early contraction? Are you familiar with cardiac anatomy at the ear? The terminology, suppose if you don't understand, you please let me know, I will explain. So mitral valve annulus is located in atrioventricular groove level. It also moves because it is pulled by the myocardium. So during systole it moves towards the apex. During diastole it moves away from the apex. So if there is any abnormality of the myocardium, as well as even if there is an abnormality of the mitral valve annulus, we know that okay, something must be wrong with the myocardium. So we try to assess the regional wall motion abnormality. For that we have a scoring system. Normal is 1. That I will explain, not a problem. So that we assess. What is diastolic function? Ejection fraction is systolic function. So systole, diastole, we are familiar. Systole is contraction, diastole is relaxation. So if the systole is happening good or bad, we assess by ejection fraction, and also there are so many other parameters. So as a simple report, we usually include main. In a given abnormal case, we add a few more things, and we can always add few lines. Suppose if you want to give more details. So systolic function is assessed by ejection fraction as well as regional wall motion abnormality. Both are systolic functions. Diastolic function is assessed by combination of parameters. So that I will discuss later. What is diastolic function? Let us understand. According to you, what is the diastolic function? Filling of the ventricle. Yeah, ultimate goal is filling of the ventricle. But what is diastolic function? With reference to myocardium. From myocardial perspective, not with the perspective of the cavity. Yes, relaxation. Yeah, relaxation. So the diastole means relaxation of the left ventricle. The purpose is to receive the blood. To receive the blood, what is important? Change in the pressure. The water moves from high velocity to low velocity. It's a fluid mechanics we have studied in PUC. We know. If you have a high chamber, high pressure chamber and low pressure chamber, if you connect with a pipe, naturally from high pressure to low pressure, fluid will move, isn't it? So if the mitral valve has to open, if the flow has to happen towards the left ventricle from left atrium, what has to happen? Pressure variation between LA and LB. We should be higher, we should be lower. LA should be higher, LB should be lower. How it can be achieved?
Volume can be increased. Volume increases area, pressure will decrease.
Okay. Even there is a volume increase means once again relaxation. Ultimately, it comes to that. So basically, left ventricle has to relax, and it should make way, make a situation where the pressure drops. So what is the left ventricular pressure? Do you know what is normal left ventricular pressure? Okay, what is aortic pressure? Okay, 120/80. Brachial pressure is same as aortic pressure approximately, yes. Then what is left ventricular pressure? So little bit of extension of the same whatever we know. All chambers will have normal pressures, right? What is venous pressure? In peripheral veins, what is the pressure? Yeah, you have single digit numbers, yes. So you can take a guess. What could be the LV systolic pressure? Systolic pressure only. Aorta is 120. LV systolic? Why less? Because pressure in the aorta is generated because of the left ventricle itself. Left ventricle is a root cause for the pressure creation. So it has to be equal. So systolic pressure of the left ventricle is equal to the systolic pressure of the aorta. That is fine. Diastolic pressure. Diastolic pressure in aorta is 80. What about in left ventricle? How less it is? Take a guess, give you a number. 16. 60. Okay, he is telling 60. What is LA pressure? You told 10, right? LA pressure 10 or 15 you told. It is usually 10. If the LA pressure is 10, if the LA pressure is 60, how flow is it? Yeah, see, someone told 0. It is correct, actually it is near 0. Usually 5. Near, of course, it varies from person to person and variation. Basically, the LV diastolic function purpose is to create a situation where LV diastolic pressure drops to as low as possible near 0. How it is achieved? By? Yeah. Why you are telling isovolumic? Why not whole face? Why you are targeting only specific face?
Because that phase, like both the mitral valves and the aortic valves will be closed, and the negative pressure will be created, just pulling the papillary muscles.
Negative pressure is created, but nothing is getting pulled because no movement is happening. So you are right actually. Basically, the pressure drops during, it's a continuous effort during the diastole, but when the mitral valve opens, the filling starts. Naturally, the pressure, there will be some amount of fluctuation, but ultimately goal is to reach near 0. Because you mentioned isovolumic relaxation time, okay, let us talk about that. It is relevant in even in fetal echo. What is IVRP or IPSP? Isovolumic relaxation time, is it happens before diastole or after diastole?